你碰到Oh. All right. Hello, everyone. Today we're going to talk about computational psychiatry. I'm the assistant professor here in U of A. I'm also the Canada research chair in computational psychiatry. So in this talk, I will just explain what exactly is computational psychiatry, and I'll introduce some examples, how we use computational tools, especially machine learning tools, to solve some psychiatry problems. Some disclosure and disclaims, no conflict of interest. Maybe I'll just move this a little. Okay, no conflict of interest, gratitude to be situated on Treaty 6 territory, and all the contents in this talk is just my personal opinions. The figures used may belong to the original owners. So first, I want to give some introduction about mental disorders, as not everyone here in the audience might be from psychiatry. And then I will introduce computational psychiatry, and then I will give some examples about applications. And after that, Fernanda and Yipeng, they are my trainees in the lab, and they will also introduce some of their own ongoing projects. So when we talk about mental disorders, it's people think about like things like depression, anxiety, sometimes maybe schizophrenia and other things. But there are also some confusions about mental disorders and the neurological disorders. There's a history of why we name it this, the so-called mental disorders, now mental disorders. So basically, when we think about some disease that change the way of people's thinking and behavior, and sometimes even perception, so we think about those as mental disorders. But these days, so remember, like more than 100 years ago, that's reasonable. So basically everything relevant to mental, it's just mental disorders, are mental disorders. But these days, because the advancement of the scientific techniques, so we know that now that almost all the mental disorders, they are actually brain disorders. So it's a similar thing like Parkinson's disease, epilepsy, multiple sclerosis. They are also brain disorders, right? So they are typically considered as neurological disorders. So, but we still consider mental disorders or psychiatry disorders as the typical, the mental stuff, and the one that we know that can be peripheral or can have a very clear trace in the brain, but also not directly affecting how people think and behave, are neurological disorders. So when we talk about mental disorders, as I said, usually we talk about depression, bipolar disorder, anxiety, schizophrenia, and maybe ADHD, OCD, anorexia, those things. So from two perspective, I just want to talk about the burden of the mental disorders. Back in 2008, there was an estimation in Canada. It actually cost, every year it cost about $50 billion US, and that's actually about 2.5 to 3% of the GDP. So I did my own estimation now, just using some trajectory. And this actually includes both mental disorders, substance use disorders, and self-harm, and also neurological disorders. So for now, the cost is about 70 to 80 billion US dollars. So that's about 4 to 4.7 GDP of Canada. So you can imagine that 1 in 20's GDP is actually spent on dealing with these disorders. And it's very typical that this percentage and cost they are higher in developed countries compared to developing countries. The data is just it's a way to measure the disability adjusted life years. So basically, you know, if someone is disabled and cannot go back to their normal life, that's actually we discount that life years to that disability. And back in 1990, the top one is actually the circulatory, like the heart disease and other blood disorders. And then the next one is usually cancer, and the mental disorders is just maybe the fourth one. But in 2015, this thing changed. So we actually made a lot of progress in dealing with you know, heart disease and cancer, but not so much for mental and behavioral disorders. And now the mental and behavioral disorders is the top burden if you consider as disability adjusted life years across all the disorders, right? So this include the cancer, include the heart disease, include even injuries, you know, like car accident, all those kind of things. But this is actually very high. It's actually now the number one burden that we have to deal with. In Canada, the prevalence of the mental disorders is about 20 to 25%. Back in, I think 2008 or 508, this number was about like 6.7 billion. Sorry, 6.7 million. But nowadays it's almost close to 10 million just in Canada. And in Alberta is roughly 25%. So if you consider like the health utilization relevant to any mental illness every year. So every year you will see about 1 million unique person, you know, or individuals to, you know, every year in Alberta relevant to mental disorders. So it's a lot. It's roughly 25% of the whole population of Alberta. So that's actually the overall burden of mental disorder. And from the dispensation rate, just to give you an idea of the increase, for the antidepressant and the anti-anxiety drugs, so we can see a lot of dispensation. It's the raw number, as you can see on the y-axis. And the percentage is also increasing over the years. If you just calculate the dispensation, we have like, you know, 12% back in 2010. And in 2018, so this number is still increasing. 2018, we are already like exceeding 15% of unique individuals. It's a lot. I think now it's even higher. And this number, sorry, maybe I'll just move this a little bit. So this is actually is the figure. This is actually the data that you can even see on Alberta's own substance use surveillance data. So it's actually interactive dashboard. The top one is about any substance use, and the blue bar is I think it's a total number. So this is the total number of deaths relevant to any substance use, and the yellow bar is the rate per 100,000 person years. So we have like roughly over 1,000, like, you know, 1,100 deaths relevant to any substance use. And the opioid alone, we'll talk about almost 1,000 already. So you can see that the majority was due to opioid, actually. So we have like 1,000 deaths back in 2020, just due to opioid. So it's, to me, it's a high number. And I'll show you like this number, actually a lot of them are preventable. Yeah, sorry, this data is a bit outdated. So this is actually 1 year ago. When if you compare the same data for 2020 up to I think 2021 March, you know, the total COVID-19 deaths back then was 1,900. So you can see that just opioid alone can just claim, you know, this many of deaths. And if we actually take a look at the health service utilization within 30 days of the death, and the top panel was about non-pharmaceutical opioid deaths, more than half of them actually at least use the health service, within 30 days of their death. And if you only consider the pharmaceutical opioid related deaths, actually over 86% of them used our health system in Alberta. So you can imagine these deaths, if we know something within the 30 days of their death, we might be able to do something. So they are actually, to some extent, at least to me, they are highly preventable, especially those with pharmaceutical opioid related deaths. So we have several limits in our current mental health services right now. The first thing is the whole diagnostic system is based on symptoms. So we never say that fever is a disease, right? We know it's a symptom that can be caused by several possible diseases. But when we talk about depression, we kind of consider depression as a disease. So in fact, depression is just a symptom that caused by several potential diseases maybe, but we don't even know like what kind of diseases are those. We just currently we just diagnose the depression as a disorder, right? It's just one of the symptoms of some other disorder, but it's still based on symptoms. For the treatment, we also have very low efficiency and high cost treatment strategy these days. And usually we just use the top tier drug, and it's not personalized. And current data show that for the first treatment, especially for things like depression, usually for the first treatment, we only achieve like less than 50% of response. So the majority of the patients, they didn't get treated well for their first treatment, and they have to try different things across time. We also lack of accessible long-term support because it's very typical in our health system that we want to discharge psychiatric patients, and it's okay for the acute symptoms, but some patients, they may lose their ability to live alone, or they may need a lot of help. So usually our long-term support is not sufficient to support those people. We do have a community support here in Canada, which is very good, but in US sometimes you can people got discharged within 2 weeks, and some like severe, for example, schizophrenia patients, they need a lot of support, but they may not have sufficient support from the community. So it's and they didn't get back again, right? So later in the future. So it's a bit it's very unfortunate and also very complicated to solve. And mental disorders, they're already very complex, right? So currently we don't have biomarkers for them, like very specific biomarkers. I'll talk about this more later. So that's why you can imagine that we need evidence-based diagnosis and reliable biomarkers, not only biomarkers, even some markers. I can mention that later. We also need treatment outcome predictions, and we also need a personalized medicine in mental health. Eventually, we hope to achieve that, but that's going to be a long way to go. So we need a big data approach. We need all kinds of data to help us to collect the evidence, but we also need the computational tools to help us to deal with this much data. So that's actually where we get computational psychiatry. And this is a busy slide. You don't have to go through it. If you are interested, you can read this paper by Fernandez back in 2017. And they talk about precision psychiatry. So these days we have a lot of data around each person. And we may have like physiology, environmental factors, cognitive factors, and all the like imaging data and health records. And sometimes we also have data from smart devices and the cell phones. And we also have what we call the panomics, like the genomics, metabolomics, all those kind of things. This is actually the big data approach we talk about, right? But we also need computational tools to eventually achieve a personalized or precision psychiatry to each individual, and to optimize their prognosis and also the treatment. So that's actually the goal for us in the future, and the approach to achieve precision psychiatry. And one of the approaches will be computational psychiatry. So precision psychiatry may redefine psychiatry. As I mentioned before, even the diagnostic system now is based on symptoms, right? So what we currently talk about, for example, like schizophrenia, schizoaffective disorder, or bipolar disorder, once we consider all the pathophysiological ideas and all the other factors, we may actually regroup them into different subgroups. They may not have the same name anymore, right? They may actually totally like shuffled again, but each of the new group, we may have ways to do early detection and to have the best treatment for each of the group. So when we talk about precision health and precision mental health, there are some things to consider. So first of all, no health without mental health. So our current training for medical training is a bit segmented, right? So the physical disorders and the mental disorders, people have different expertise, but from the patient perspective, they just want to feel better, and the physical and mental disorders, they are actually interlinked, right? For example, the pain may cause anxiety, and also depression may cause some somatic disturbance as well. So it's always cross-linked. There's no way that you segment these two components of each person's health artificially, and that's also true for precision health. So no precision health without mental health. And as I mentioned, precision health is not only about biomarkers. So we tend to look for biomarkers, but there are other like social and clinical cognitive behavioral factors that we need to consider. So it's not only about biomarkers. And from the big data, we need to borrow some of the computational tools, right? So because the big data, they are high dimensional, they are heterogeneous, and what we try to achieve is the personalized diagnosis and treatment optimization. So all this, we need a lot of data to help us to make the decision, but we also need advanced computational tools, and that approach we call computational psychiatry. So usually these two terms, they are not combined together, but this is actually an emerging new field that we call it computational psychiatry. So computational psychiatry usually has two components, and one is the data-driven, and the other is theory-driven, and they do have an overlap. The field I'm working on is primarily data-driven, and so basically, we try to use all kinds of data we get to try to improve the diagnosis and treatment outcomes. But they're also theory-driven, so it's somehow similar to computational neuroscience, right? Because all the psychiatric disorders, they have origin of the brain. So there are a part of the efforts in the computational psychiatry field that people try to build an abstract model or theory of the brain and they try to use that theoretical model to explain psychiatric disorders. So, for example, again, this is just a busy slide, but it's an example using the computational neuroscience perspective. So, for example, you have the vision system from the eyes to LGN, then to visual cortex, and then to the frontal areas. So, based on this physiology observations, we can actually understand. We can actually make a model for the visual system. Something like on the left, and there's like feed forward and feedback connections. So this is actually the origin of the neural networks, right? And then once you have like stacked neural network layers, you have deep learning, neural networks. So once you have this kind of thing, you actually can say, okay, the model, the visual perception should be work like this way, and we have this model, and it can explain what we observe from physiology and also from behavior. And if some part of this system is disturbed, you can actually observe some change of the behavior. So it's the same logic in the theory-driven computational psychiatry, that we have a model for this for certain disorders or for certain symptoms or for certain outcomes, and then we try to explain, okay, if the part of this model is disturbed, what kind of expected outcome from this model. So eventually we will have overlap between these two. So it will be an integrated model with the theory-driven and also with the data-driven model, and we will actually integrate them together eventually. So for those of you interested, you can actually take a look at the Michael Franks Labs link. So one of the very strong tools that we use in computational psychiatry, in addition to statistical analysis, is machine learning. So when we talk about machine learning, it's only a small part of artificial intelligence, or AI. AI actually has a lot of other things to deal with. So it's dealing with anything generally about intelligence. Man-made intelligence is artificial intelligence, right? Anything relevant to intelligence that will be relevant to AI. If the human try to make something that we think has some intelligence component, but machine learning is mostly about learning the pattern of the data and try to solve a very specific problem. And deep learning is actually part of the machine learning, and it's just a specific form of machine learning that use neural networks. So in my own research, I try to achieve precision medicine in mental health, and I try to combine. So if you speak in a fancy way, I try to combine mental health and AI together. But most of the time, I'm using machine learning to solve the problem, and with the big data approach and other approaches to fuse the data together and try to solve the problems for mental disorder, specifically to predict diagnosis and treatment outcome at the individual level. So why we use machine learning in psychiatry? First of all, it actually can predict new data. So I won't actually go any deeper for the introduction of machine learning. For those of you who are interested in this, there are tons of things now online. So basically, what we are interested in, we want to predict at the individual level about the diagnosis or about the treatment outcome. Machine learning can provide that kind of individual level prediction, which is very nice. It actually can also generalize to new data through cross-validation and through other ways, something like regularization to avoid overfitting. So it's actually we actually know how well the model can be generalized to new data through a standard process of validation. So those two things are most important for me, because the traditional statistical analysis, which gives just significance of some things, that cannot guide me in the practice, right? To say, okay, we should use this treatment or this person will, based on the data, for example, brain scans, we can say this person has this disorder and should be treated with this. So we cannot directly use statistical analysis to do that, but machine learning can help us to achieve that. And it can also help us to select what we call the features, or you can imagine that it can, among the high dimensional potential predictors for diagnosis or for treatment outcomes, the machine learning algorithm can help us to select the most predictive ones. So again, one step forward from the group level statistics. So I'm not saying that statistical analysis at the group level is not important. It is a very important first step, but it's not the final step. So for example, for the COVID-19 test, we actually currently have a very good COVID-19 test. I think the sensitivity is above 99% now, and the specificity maybe 96 or something like that. It's very high. So because we have a very clear biomarker, right, to detect for the COVID-19 virus, we don't have it for mental disorder. It's not possible for most mental disorders. And just like example for the CT, like from the group level to individual level. So basically, for example, we know that the infection, if the infection go to the lens, and we know that from the CT scan, it's whitened in certain region of the lens. And if you test this, like if you say, okay, the statistical group level statistical analysis will show a significant change or whitening in the lens, right? But how much of the whitening can we use to guide? For example, there's a new patient coming in, and we do a CT scan. How much whitening can we define? This is actually due to COVID-19. So that is really hard, right? So you can have like a really significant group level test results, but to push it to the new patient at individual level, it's really hard. So that's actually what I'm saying, that the group level things will help you to narrow down certain things, right? But to push it to the individual level is really hard. But now on the CT scan, we actually have like things like based on deep learning that can help us to facilitate the diagnosis. So it's a really subtle thing to determine like which part of the lens and how much whitening can we say that, okay, this is actually due to COVID-19, just based on the CT scans. So, we look for like predictivity, we look for generalizability, and we also need a feature selection. That's what we need from machine learning, and we use machine learning a lot. And group level analysis is just a necessary first step. It's not final, it's not clinically useful until it can be applied to new individual patients, and machine learning can provide this. So here I just want to give you guys some example that what we use machine learning for. So this is actually one of my papers published online in 2018, but it's actually published officially in paper 2020. So here we use what we call the functional connectivity of the brain, so which was measured by functional magnetic resonance imaging. So we find certain part of region, like the temporal part of the brain, connect to the remaining part of the brain. This connection is different in first episode drug-naive schizophrenia patients. So, and well, just one more explanation why this is important. It is important to use the first episode drug-naive patients, because disease will progress, and and also the drug will also affect anything we observe from the brain. So if you have a chronic patients, anything you observe from the brain, they may due to the progression of the disease. They might be even triggered by the drug. So we don't know whether those brain changes we observe was actually due to the disease itself, or due to the progression, or due to the drug. So the first episode drug-naive patients will give us a better idea. This might be due to the disease alone. So we actually observe the fMRI signal from these patients. And we actually use the functional connectivities from this superior temporal region to the rest of the brain, and use that functional connection data to make predictions of the disease itself, as well as the treatment outcome. So the bottom left, that the figure you see, the x-axis is what we call the PANSS drop after treatment. So the PANSS is actually a symptom scale. The higher the worst of the worst the symptom. PANSS drop usually indicates improvement, and the y-axis is the predicted PANSS drop. So you can see there's a high correlation between this actual and the predicted PANSS drop. So the prediction was based on machine learning, and it's far away from perfect, right? A perfect prediction, you should see a line. You should see every single dot here, which is the single cases here. They should align on the line, but we see some random part here indicating the model is not perfect. But in mental health, this is very rare that we can make this kind of individual predictions like this. So this is already quite accurate for the mental health. So it's not comparable to some of the other physical disorders that you will achieve something like over 90 or 99% of accuracy. And based on this predicted symptom improvement, we also can predict who will be the responders and who will not. So the average, the balance accuracy is over 80%. So it's very high actually for mental disorders. And using the same logic, we can also predict the treatment response to electroconvulsive therapy. And we are using hippocampal subfields. So hippocampus is a region that is responsible for memory, and it's also involved in emotion regulation, because it's actually next to another nucleus called the amygdala. We use hippocampal subfields, and we build a machine learning around the hippocampal subfields volumes, and try to predict who will respond to this electroconvulsive therapy, or ECT. So ECT is actually a treatment that you see in some movies. It's actually triggered a seizure in the patients, but it's actually surprisingly really effective for depression. And but of course, it's kind of invasive, right? It's not just it's not harmless. It also has some side effect, especially for the short-term memory loss. So the motivation behind this is, if we know that this person will not respond well to ECT, we can avoid this invasive treatment and use something else. So by using hippocampal subfields volumes and machine learning algorithm, we can actually predict the treatment response. So here, when you see the Hamilton depression scale, it's a HAM-D. Here, it's also just a symptom scale. So a decrease usually indicates improvement. And the x-axis is the actual decrease of Hamilton D. The y-axis is the predicted one. So you can see that actually our prediction was quite accurate, and we can actually we can identify the remitters and non-remitters. And we also can do something new. For example, discover new pathological hypotheses. So here we use the structural brain images to try to classify bipolar versus healthy people. But through the features or the predictors we find across the brain, we actually can use those features to even identify the neural progression of bipolar disorder. So we actually can differentiate different stages, like the bipolar early stage, moderate stage, or late stage, and even bipolar, another type of bipolar disorder versus healthy controls. And we actually can see a gradual change at different stages in certain brain regions. So that's actually give us some new targets that we didn't expect using machine learning. This slide, we actually try to identify lifetime suicide attempters And we are not even using some biomarkers here. We are using some, like health relevant or social markers, or even demographics here, right? We use, like ethnicity, sex, age, and previous hospitalizations, and some other mental health conditions, and we can actually identify the lifetime suicide attempters. So more recently, you will see some social media company, they try to predict suicide based on the post or tweets. So this is actually a hot area right now. And we also use machine learning in administrative health data. And so on one hand, on what I call micro level, we actually can try to predict individualized clinical outcomes. On the macro level, we also can try to identify the risk factors and protective factors. And the individual level prediction will be really helpful for clinicians and the patients. But the macro level will be really helpful on the health system level for decision makers. But eventually, we try to achieve precision medicine, precision public health. So this is actually also a new emerging area, probably less than 5 years old. And public health, people may be familiar, but the precision public health is, think about we try to use all the data or all the evidence to actually provide information or even intervention at the right time to the right population instead of the individuals, right? That's actually what a precision public health want to achieve. And we also have computational psychiatry as an approach to achieve precision mental health. And we can make evidence-based decision making for policymakers and other stakeholders. And eventually, we may have data-driven clinical practice. We may also have data-driven health system management, policy change, program development, and even data-driven legislation. So we still have a long way to go, but that's actually how at least for my vision, that's actually the future. So this is just one example. This is not a biomarker study. So when we use the administrative health data, for example, if I go to the hospital and I see a doctor and I did some tests, I get this drug, all those information the government actually collected, right? So because we have this single payer system in Alberta, and it's just like the big insurance company, right? So the whole thing will be recorded. And so by using this de-identified administrative health data, we actually try to predict opioid use disorder prospectively, which means I'll explain that later. We actually try to use all the health data, demographic data, all the relevant data in administrative data to try to predict opioid use disorder. So we try to use all the potential predictors from one past year, and then, for example, 2020, and we actually try to predict the opioid use disorder or OUD in 2021. So this is actually real prediction, right? So that's what we call the prospective prediction. And the preliminary analysis showed that we actually can achieve 86% of accuracy of individual prediction of OUD. So in about 1.2 million people. So the balance accuracy is actually 86%, and you can see the sensitivity and specificity in the confusion matrix that we show here. So it's actually quite high. So this slide is credit to another of my young colleagues, Yang Liu. So in the next couple slides, I will ask my trainee here, who actually kindly joined us to introduce themselves and also part of their work here. So first we'll have Fernanda. Fernanda, are you there?
Hello, yes. Oops. My name is Fernanda. I'm a PhD student with Cloud. I'm entering my third year now. I'm from Brazil. My city is São Paulo, and as you can see, it's totally different from Edmonton, but I'm actually glad that I'm here in the city with a lot of greens. And I came here to Canada with my husband in this photo, and we recently adopted a cat. Scientifically, my background is in psychiatry and genetics. In my master's, I studied two groups of people. So one of them were patients with schizophrenia and the other one were control. And the main objective in my research was to find the major genetic variants associated with the diseases and other social and environmental factors. But now during my PhD, my main objective, although it continued with psychiatry, that there's nothing to do with genetics anymore. Now I'm working with cloud with Alberta health data. And the objective of my PhD is to find how mental health related utilizations such as physician claims, emergency department visits, and inpatient data, especially in children, adolescents, and young adults, how this mental health utilization changed between 2016 and 2021. And specifically, we want to see if the trend of utilization from 2016 to 2019 differs from those from 2020, 2021, after COVID came. And we are also investigating some risk factors or predictor factors associated with these mental health utilization changes.
Thank you, Fernanda. We also have Yipeng Song here. Yipeng, are you there?
Yeah, sure. Okay, I think I think we can skip this slides because this is me about my previous research at the University of Amsterdam in the Netherlands. Before I came here, I did my PhD research over in the Netherlands for 4 years.
Okay, so yeah, you deal with heterogeneous information, but probably we won't go into details here.
Yes. I think my current research focuses on the two lines. The first line is aging research. I think the aging process with people get old, they are more likely to be they are more likely to develop the chronic diseases such as the heart disease or the cancer, and however, the age itself is not a very good measure of the aging process. We have many people, they have this exactly the same age, but they have very different health conditions and different functions. In the aging research, we have a new concept. It is called the biological age. We define the age based on the objective biological measures, and this biological age should reflect the true aging process. So my work here is to develop the new biological age based on the data we have, and also to discover the risk factors associated with we call it the abnormal aging process. Another line of research is the risk stratification. I think if we can identify the subjects with a high risk for developing the mental disorder, for example, the depression and the anxiety, we can do early interventions on these subjects. It may prevent them to further develop this mental disorder, or it will mitigate their suffering from these mental disorders. However, to achieve such a goal, we have to identify, we have to have we call it the individual level risk prediction. My work is focused on this area using the machine learning models and on the survey data to develop models to do the individual level risk prediction. Yeah.
Thank you, Yipeng. All right, so I would just like to thank my supporters and founders and collaborators. And we have a big team. This is actually not even the most updated one. We have even larger team in the upcoming year, and we'll always look for young talents and look for collaborations with any, with doctors or with potential doctors. So you guys in the audience, you are the future doctors. Yeah, so this is my information, and yeah, feel free to drop me an email, and yeah, that's answered my talk. Thank you everyone for your attention, and thank you, Ipo and Fernanda, for joining me.